The purpose of this project is to decrease the incidence rate of self-harming behaviors from 35% to 10% of adolescents with borderline personality disorder on the psychiatric unit by using evidence-based dialectical behavioral therapy. Patients diagnosed with borderline personality disorder are known to self-harm even in a safe environment, causing a large safety concern on psychiatric units. Though BPD is reported to be responsible for 20% of inpatient mental health admissions, it is responsible for 65% of my unit's yearly census. It begins in adolescence and oftentimes identified by inadequate coping skills such as self-harm. Reported by Capel in 2016, 70 to 75% of individuals diagnosed with BPD have a history of at least one purposeful incidence of self-harm. In association with the beginning stages of diagnosing such a disorder, self-harm incidence occurs on the unit weekly. This mental health issue is challenging to treat, and currently there are no group or individualized therapies on my unit that target these behaviors. Borderline patients can self-harm in such extreme manners, mutilation is responsible for 8 to 10% of suicide. The National Institute of Health and Clinical Excellence recommends considering dialectical behavioral therapy. Given the substantial number of borderline patients admitted to the adolescent psychiatric floor, Zahn, Matheson, and Courtney suggest a combination of strategies including initiation of dialectical behavioral therapy as well as changes in nursing staff to contribute to self-injurious reduction. BPD is associated with higher costs when persons with the disorder do not receive evidence-based psychological treatment specific to their diagnosis. By using DBT, the mean cost savings for treatment of patients with BPD is around $3,000 US per patient per year. Utilizing DBT is less expensive and more effective comparatively to treating patients without such services. DBT is effective in reducing suicidal behavior as well as the amount of days spent at the psychiatric hospital. The clinical question formed is, will patients diagnosed with borderline personality disorder have decreased self-harming incidences when a registered nurse offers dialectical behavioral therapy on an inpatient mental health unit compared to patients not receiving dialectical behavioral therapy by the registered nurse? The evidence search process was a systemic review of the effects of dialectical behavioral therapy treatment on borderline personality patients and their rates of self-harm. Research databases searched for articles published between January 2012 and November 2017 that reported on any relationships between the keywords dialectical behavioral therapy, borderline personality disorder, and self-injury. PsycInfo and Cinehall databases retrieved relevant articles that met inclusion criteria, which was the following: uncontrolled and controlled trials, adolescents 13 to 18 years of age, English language, human research, and psychiatry and nursing articles presented in PDF format. The number of articles retrieved in PsycInfo was 26. The number of articles retrieved in Cinehall was 16. 5 articles from PsycInfo and 2 articles from Cinehall were used in the systemic review. Before the advanced search, 762 articles were originally retrieved. Exclusion criteria included level of research evidence less than 3, other psychotherapy models that presented in articles unrelated to DBT, and unrelated mental health diagnoses that did not have comorbidity to borderline personality disorder. By compiling the various studies and presenting them with an appropriate vehicle for change in practice, the hope is to decrease the amount of patients who self-harm on the inpatient psychiatric unit by providing nurse-led DBT. Through the literature, it is evident that children who receive DBT self-harm less and have a decrease in other suicidal tendencies. The literature does not provide evidence that DBT led by nurses specifically is significant to this relationship. Based on the review, the EVP committee recommends the following. 1. The Child and Adolescent Psychiatric Unit should revise the group therapy protocol to include dialectical behavioral therapy into daily programming. The rationale for this recommendation is because DBT intervention is a treatment option useful to adolescent borderline patients who have high-risk behaviors such as self-injury. 2. The Child and Adolescent Psychiatric Unit should measure the effectiveness of DBT treatment on the inpatient unit at patient discharge by gathering the incidences of self-injury during admission. The rationale for this is to provide further evidence showing that presenting DBT on the acute psychiatric unit is effective in decreasing the amount of patient self-harm throughout admission. There is significant evidence to support a practice change to involve DBT into the patient's daily routine on the mental health unit. However, there is less evidence indicating the need for nurses to guide DBT programming. To change policy, ongoing research regarding the effects of nurse-led DBT and rate of self-harm must be continued. The IRB must analyze the intervention, DBT, in reaction for the patients involved by reviewing the proposed method for research to ensure that it is ethical. Since it is recommended that ongoing research is to be continued before implementing policy change, IRB's involvement is significant for the mental health unit to begin the process. The Child and Adolescent Psychiatric Unit must seek approval from this committee before implementing research and change. For nurses to begin leading DBT group programs, the Stettler model will be used as a framework for the proposed evidence-based intervention. The Stettler model adopts research at the bedside by following the 5 stages of step-by-step instruction for integrating research into practice. First, evidence will be prepared to illustrate the relationship between DBT and self-harm. Since self-harm has a decreased rate in correlation to patient participation in DBT, acknowledging the literature is imperative. Next, in Phase 2, validation will be completed through further critique and review of qualified studies represented on the previous stages in this project. Previous literature has been thoroughly investigated. Since there is minimal evidence regarding the efforts of nurse-led DBT, Phase 3 of the Stettler model will include collecting data in the current practice setting to use as evidence for the need to implicate nurse-led DBT into the clinical setting. The data collected will include incident reports of self-injury on the unit since October 2013 when the unit opened. The amount of reports and severity of self-harm will indicate the need for intervention to prevent such occurrences. The stakeholders of the hospital will then need to make a decision whether to implement DBT to the present group therapy program guidelines. Phase 4 of the process will be applying the findings to practice. The application of EBP will be implemented by RNs. Lastly, in Phase 5, a formal evaluation of the plan will be finalized. There is little, if any, risk in implementing this plan as it can only enhance the well-being and safety of patients. To engage staff members, an open discussion about the EBP will be conducted. The education required to teach DBT affects only the nursing staff as they are the targeted population to guide the therapy. DBT certificates can be obtained through workshop courses in the local community. Courses can be costly, up to $100 per person, so it is imperative that classes are financially managed by the hospital. Since the Child and Adolescent Psychiatric Unit is a floor that brings in significant amount of income with very little expenses for resources, their certification costs can fit into the unit's budget. Upon new hires, it may be ideal to employ nurses already certified to teach DBT. If new nurses are not already qualified to do so, it would be acceptable to request the completion of such by the end of his or her probation period. There is no new equipment or supplies needed to implement this change on the unit. A pilot project will be implemented to evaluate the intervention to identify if applying DBT to everyday programming is effective for patients. During the pilot period, DBT courses will be paid off for full-time nurses only. There are 4 full-time nurses, which adds to about $400 of investment for the certificates. The unit staff will have a face-to-face consultation on the new protocol implementation. To measure outcome, nurses will first collect incident reports for self-injury between October 2013 and December 2017. These occurrences will be compared to the self-harm rate 3 months post-nurse-led DBT programming. Patient survey and incident reports will be utilized as instruments for measurement. The survey will be given at the time of patient discharge. The RN is the individual responsible for all discharge paperwork. Survey questions will inquire about the urge to self-harm during admission versus acting out on the urge. It will also ask the individual what prevented him or her from the act of self-harming. Lastly, patients will be asked to rate all group therapies and their effectiveness on the patient decision-making process to utilize healthy coping skills. Additionally, copies of self-harm incident reports will measure the statistics and percentages regarding actual rate of occurrence. Based on the survey answers and percentages of self-harm, stakeholders will decide whether to implement this policy officially. There will be opportunity to discontinue DBT programming should it be deemed ineffective after a 3-month pilot trial, that is, if self-harming rates are not significantly decreased. If positive change is indicated during the short-term policy implementation, continuation of nurse-led DBT will be maintained as protocol. The overall hope is to provide advanced therapy by a licensed health professional in an effort to decrease the amount of self-harming incidents on the inpatient pediatric psychiatric unit. If nurse-led DBT is sustained, it is important that all RNs on the unit are certified to provide this therapy. It would be ideal to provide financial coverage to a current hospital worker with employment longevity to become certified as a DBT educator. The expense of training an employee to be certified in DBT education would save the collective financial burden to cover costs for RNs to be certified elsewhere.